Good evening, everybody. I am Dr. Sarah Al-Wali. I am a consultant gastroenterologist at the Cleveland Clinic in Abu Dhabi. Welcome to our first inflammatory bowel disease patient education webinar. So this is the first IBD patient education webinar that we're organizing. We had organized something similar a couple of years ago, but this is actually going to be a new virtual series, and it's going to be a series of really educational sessions about inflammatory bowel disease, which is Crohn's disease and ulcerative colitis. And this is really meant to be for patients, for their families, and for people who care for them. We will hope, to help educate you on the disease, give you tools to better care for yourself or your loved ones. It's brought to you by the Cleveland Clinic Abu Dhabi IBD team that you're going to get to meet today and over the next few sessions. We're here for you, so ask any questions you would like. Don't hesitate. Everything is okay. So this is our IBD team. It's actually a pretty big team. It starts with the patient and with GI doctors that are there to take care of your Crohn's disease or your ulcerative colitis. And then we have specialized surgeons in IBD that we work with all the time, very closely. And we have an IBD Nurse Coordinator, Marie, who you're actually going to meet later on today. We also have dietitians and other specialists like, rheumatologists or skin doctors that can help with, any other aspects of Crohn's disease or colitis. Patient educators, you might have met them already in our clinic, infusion team, nurses, social workers, etc. So there's actually a big village and team of people taking care of you. When you come to clinic to see us, there's a lot of people in the back that you're not seeing. So these are some of the topics we want to discuss over the next few sessions. One of them is understanding inflammatory bowel disease, which is really important. We're going to cover COVID and IBD. That's going to actually be for today. And for the future sessions, we're thinking of doing things like, covering how do you live with IBD, what should you eat, is there any specific food or diet you should be on, how do you do when you want to travel with the medications, how do you cope with the stress of Crohn's, colitis. We get a lot of questions on pregnancy. If you want to get pregnant, is there anything special you need to do with the IBD? We also want to cover next, research and new treatments for IBD and surgery. But you're the patients and we want to hear from you. So if you have any ideas of topics you want us to discuss, please write them down in the chat box, okay? And we'll cover this in the next few sessions. For today's program, after this welcome introduction, you'll have Dr. Alam, who will give you a talk on what is IBD, what is inflammatory bowel disease. Dr. Alam is one of our consultant gastroenterologists in the IBD program. After that, I'll be talking to you about COVID-19, what you really need to know, followed by Dr. Zahir Kutubi, who's another consultant gastroenterologist here in our IBD program, that will be giving you a little bit of an idea on our program and how we do things at CCAD and how we're here to take care of you. And then Marie Maynard, our nurse coordinator, will tell you a little bit more about her role. And then after that, we'll have a live Q&A session for you, where you can ask all the questions you'd like. All right, so without further ado, I'm gonna actually pass the mic to Dr. Mohammed Alam, who is working with us in the IBD program, and he's gonna tell you a little bit more about IBD.
So hello everyone, my name is Dr. Mohammed Badre Alam. I'm one of the consultant gastroenterologists at Cleveland Clinic Abu Dhabi. And thank you, Dr. Al-Wali, for a kind introduction. My job today is to talk about, basically, just to give a brief introduction of what is inflammatory bowel disease. So it's a group of disease which affects the digestive system. So we are talking about stomach, small intestine, large intestine, and it's mostly, in most of the cases, it will be confined to either small intestine or large intestine. We divide it into two groups generally, called ulcerative colitis, which usually affects the colon or the large intestine, or the Crohn's disease, which can affect small intestine and large intestine, both of them, and sometimes even stomach or esophagus or mouth. What is also very important to understand that although we call it inflammatory bowel disease, it can very frequently associated with other symptoms like joint pains, skin diseases, or eye problems. Now, we don't understand why does it happen. So the cause is still very unknown despite a large amount of research going into this area, because if we understand the disease, why does it happen, we are much better in developing treatment for these conditions. What we do know that this is not an infection, hence it's not contagious, that you cannot pass it to someone else. What we also understand that this is something which is related to the body's immunity system, which has somehow become confused and identify your own organ as an alien. So it thinks that the large intestine or the colon or small intestine is not part of your body and starts attacking them. Why did this particular process start? Unfortunately, we don't understand very well. We also know that there is a small hereditary risk, although the risk is not very high. But if you have a first-degree relative with inflammatory bowel disease, you have a slightly higher chance of developing the disease. It can affect any age, but the majority of the patients will fall between age 15 and 40, which is obviously our most productive era of our life, when we want to do things like going to university, getting married, working, and so this is the age group where the disease usually affects. Saying that, we are definitely seeing a small rise in a group of in elderly patients with inflammatory bowel disease. What I do want to discuss a little bit more in details is the risk of disease happening more in developing nation. And I'm going to spend next few seconds on this slide. As you can see in the slide above, the blue area, which is the subcontinent, Asia and Africa, have a very low prevalence. So the current chances of having the disease in those areas is very low compared to, say, for example, America or most of the Europe. Now, if you look at the slide picture below, you can see the area which is Africa, China, India, Asian countries, including UAE. You can notice that they all fall, the rise of the disease is substantial. So the lower picture tells you what has happened over the last 24 years. So there are countries like Europe or North America where the disease was already highly prevalent. The disease is not rising, but the majority of the new patients are coming from Africa and Asia, and that's the concern. Now, the usual symptoms patients will present is sometimes very vague because it includes abdominal pain and diarrhea, and that can overlap with symptoms like irritable bowel syndrome. What should definitely make us more concerned or worried and seek medical attention is if these symptoms persist for a long period of time. If you have bleeding, if you have blood in the stool, if you have significant amount of weight loss, and I'm talking about, say, more than 5% of your body weight, and if you notice any persistent discharge in your stool or mucus, then it's time to seek medical attention. If you do not have any symptoms, and if you have persistent anemia, if you have joint symptoms, if you keep getting ulcers in the mouth, that can also reflect that you may have underlying inflammation into the digestive system. Now, how do we diagnose? So obviously, based on the patient's complaints, we have a suspicion of the disease, and then we end up doing some tests. We have some very good blood tests and in stool tests, which can help us in telling that is there any underlying inflammation in the digestive system. And if we suspect that there is underlying inflammation, then obviously the final test or the test which will clinch the diagnosis is a colonoscopy, which is an examination of the large intestine or the end of the small intestine with a camera when the patient is asleep, and that will tell us is there any inflammation or ulcer, and more or less confirm the diagnosis. Sometimes we will require to do some special type of MRI to better assess the small intestine. Can we treat this? So we cannot cure the disease. So we don't have any medication right now. We can give you a certain duration of time and can say the disease is gone. Now, we have very good medications to control the disease in majority of the patients. And the armamentarium, the number of medications we have improved or increased over last few years, not only the number of the medications, but also we have medications with better safety profile. Now, there will always be a certain subset of patients who will not treat or will not respond to a variety of medications, and unfortunately will require some form of surgery. The chances of getting surgery is higher in Crohn's disease compared to ulcerative colitis. Diet scientifically has no role in basically controlling the disease. So whatever you eat neither makes the disease worse nor makes it better. And the same applies to alternative medicine. Again, there is no scientific data to support this. But I do want to emphasize that with the current treatment, we can assure patient a very normal quality of life. So we have different symptoms which can be very debilitating. For example, particularly the stool urgency, frequency, diarrhea, abdominal pain. And if we bring the inflammation of the intestine low or under control, the quality of life significantly improves. And I'm very happy to say that with the current treatment, majority of the patient will basically live a normal life, and they will go on with their life like anyone else. I also want to very emphasize that almost all of the drug, apart from some rare exceptions, majority of inflammatory bowel disease medications are very safe to be used throughout pregnancy, and most of the pregnant women will have a normal course like any other healthy person. Can we prevent this? And that's the million-dollar question. Unfortunately, we do not have a great answer to this question. As the disease is rising mostly in the developing nation, what we call an adaptation of Western lifestyle has been discussed as a cause. So there are a lot of scientific studies going on about what role does processed food play into this. And obviously we will know the answer in future, but it appears that the adaptation of these particular food habits may play a role in the rising incidence of inflammatory bowel disease. Now, does smoking cause inflammatory bowel disease? No, but we do know, particularly in Crohn's disease, that patients who smoke are very less likely to respond to treatment. At the end of my talk, I do want to emphasize two things: that early diagnosis is very important. If we have these symptoms, which can be very vague, and particularly because the patients are young in age group, they don't tend to seek medical attention, and that leads to delay in the diagnosis. And the delayed diagnosis means patients may have more severe disease and they're less likely to respond to treatment. So I just want to emphasize that if you have persistent symptoms, which I have mentioned above, please seek medical attention, because early diagnosis is the secret of success, and early diagnosis and early commencement of treatment. And I also want to emphasize that if you have a disease which is under control, and if you see these symptoms again, that's also a time to seek medical attention to control the disease immediately rather than wait for it. And that's the end of my talk. And thank you everyone for joining again. We have put in an email there. If you are a patient of Cleveland Clinic Abu Dhabi, or anyone else in the community, please feel to email us, and we will definitely try our best to answer all the questions. Thank you very much.
Thank you very much, Dr. Alam, for this great talk on an introduction to IBD. So next up, actually, I'll be talking to you a little bit about COVID-19 and IBD and how it's impacting our patients with IBD. So I hope you enjoy the talk. So as promised, I'll be talking to you about COVID-19 and IBD and what you really need to know. So again, I'm Dr. Sarah Al-Wali. I am a consultant gastroenterologist at the Cleveland Clinic in Abu Dhabi, and I specialize in IBD. So it's great to be here with you tonight. So COVID-19, we've learned a lot about COVID-19 over the last couple of years, right? And we know it affects the lungs, we know it affects the heart, but we've also come to realize it can affect the stomach and the bowels. And in fact, COVID-19, we wrote this little summary, which basically we found out that it can affect a lot of different aspects of the stomach and the bowels. So loss of appetite, nausea, vomiting, diarrhea, and abdominal pain are some of the most common symptoms that can happen with COVID-19. So there's a very strong link between COVID and GI. But as you know, there's also a very strong link between IBD and GI. A lot of our IBD patients have GI symptoms. So how does that affect our patients with Crohn's and colitis? How does COVID affect them? Are they at higher risk because they're taking medications, right, to decrease the immune system? And what is it that you need to know? So let's cover this by covering some questions. So the first question, are people with IBD at increased risk of catching COVID-19? So let's look at what we have. So we actually have access to a lot of studies so far from many different countries: Spain, Netherlands, France, Italy, UK, and a lot of other studies. And so far, there has been no increased infection rates in patients with inflammatory bowel disease, which is actually great news. And these are consistent results over different studies. How about if we're using medications for Crohn's disease or colitis? No problem. What we found in the studies is that patients that are taking biologics or immunomodulators or any medications that decrease the immune system are safe in terms of not increasing the risk of COVID-19. However, there is a study from New York City that showed that people with IBD that were taking cortisone, steroids, prednisone, or that had active IBD, these patients were at higher risk of catching COVID-19. So how does COVID-19 affect our patients with IBD? So this is a really nice study that basically summarized the result of 23 different studies that looked at that. And what they found is that patients with Crohn's or colitis, when they had COVID, more frequently they were presenting with gastro symptoms, more frequently than the general population. So they were still having some fever, some cough, but the GI symptoms, which were, diarrhea, abdominal pain, were more common in patients with Crohn's disease and colitis, which means that patients with IBD, if they do have a worsening in their symptoms, they should really consider that this could be COVID-19 and just get tested. This is good news. This is a study that just came out that showed that, even if patients with IBD have some GI symptoms with COVID-19, these symptoms don't last too long. And so what they saw is that patients, when they followed them 6 months later, had no problems and no increased risk of, flares because of COVID. So this is really good news. So do patients with IBD have more severe COVID? We already said that patients with IBD are not at increased risk of catching it. But once they have it, are you at higher risk of severe disease? And so we're also lucky to have access to a lot of studies, including this, which is a major study. This is actually a database of more than 6,000 cases throughout the world, throughout 73 countries. And so they looked at all the patients that had COVID with inflammatory bowel disease to see, are they responding the same way? Are they doing the same? And what are the conclusions? So the conclusion of the study was that there was no increased risk of severe COVID-19 in patients with IBD, except if they had 3 risk factors: older age, which is also a risk factor that we see in patients even without IBD, if they had other medical problems, and again, this is something we see even in patients without IBD, or if they were taking cortisone or steroids. So that's one more, reason to not be on steroids. Another study from Italy showed similar things. Age above 65 and having other medical problems were risk factors to have severe COVID, and we know that, right? But even having active IBD, so being in a flare, was really inducing higher risk of severe COVID-19. And, there are a lot of other studies that I'm not mentioning here, dozens of studies that showed that it's actually, the COVID-19 is not more severe in patients with IBD. This one I'm highlighting because it's a big study and it just came out. And again, it's from France, and immunomodulators and biologics in IBD did not increase the severity of COVID-19. So this is good news. So what do we do about the IBD medications? So we have some international guidelines that we follow. A lot of experts throughout the world came together to make guidelines to see how do we proceed when we have COVID-19 and we have IBD. So first, let's start with the easy scenario, which is we do not have COVID, but we have IBD. So we have IBD, but we're COVID negative. In that case, and I'm sure you understand by now, that our goal is for you to be in remission, to feel good, not to have flares or hospitalizations or needing steroids, because those things are the things that not only make you feel bad, but will increase the risk of COVID-19. So in general, we do not stop IBD medications. You should not stop the biologics, the immunomodulators, because these are protecting you. However, we definitely do stop the steroids or taper them down as needed. If they're not needed, of course, some of you need cortisone, and that's okay because you need to get better, and that's also important. What if you're COVID positive and you have IBD? So we actually made this little table. We brought all the data together, and there's a few little things here and there that we follow as doctors when you tell us you have COVID. But the big thing is tell us you have COVID when you do, because we usually hold medications for 10 days until you recover. But again, this can be different depending on your case, but usually that's what we do. And I thought you would be interested in knowing this, that some treatments that we use for IBD actually have been used to treat COVID-19. So there are 2 studies that showed that they used infliximab to treat COVID-19 and it worked, and it's being investigated. Adalimumab also is being investigated, and tofacitinib actually was in a trial and was found to work against COVID-19, and it was just published. So some of these medications for Crohn's and colitis can actually help to treat the COVID. And can patients with IBD take the COVID-19 vaccine? I think that's a question that you're all asking. So patients with IBD should get the COVID vaccine, even if they are taking IBD medications. So far, no study has shown any harm by taking vaccines. There really is no harm in taking the vaccine. But do they work, right? Because that's another question. So this study from New York actually found that patients, even if they were on biologic treatments, right, medications that decrease the immune system, 100% of them had antibodies after the 2-dose vaccines. In the US, they were using Pfizer and Moderna. So this is very good news. Other good news, COVID vaccines really work in IBD. There's another big study in the US just came out that also found that patients that had full vaccination, that had IBD, had a significantly lower risk of COVID-19 than patients that were not vaccinated, but they had to be fully vaccinated, and this is really important. So let's say you didn't listen over the last few minutes. These are the 7 things you really need to remember and take away from this presentation, okay? So number 1, the risk of COVID-19 is not increased in patients with IBD, even if you're taking immunosuppressants. Number 2, steroids and having active IBD is associated with an increased risk of catching COVID though. So that's important because you really need to protect yourself from COVID by continuing to take your medications to make sure you don't get a flare or to make sure you don't have to be admitted to the hospital. COVID-19 in patients with IBD may present as a flare, so get tested if you do have symptoms. 4, people with IBD who catch COVID-19 do not have more severe COVID than the average, unless you have other risk factors like older age or other medical problems or active IBD or if you're taking cortisone. Number 5, if you have COVID, inform your doctor. We usually hold immunosuppressives for 10 days until you're better. Number 6, COVID vaccines are safe in patients with IBD, so please get vaccinated. And number 7, COVID vaccines work if you take the 2 doses, even if you're taking IBD medications. All right. So it was a real pleasure to talk to you about COVID. And I can't wait to listen to your questions and respond to them in a few minutes. If you have any questions in the future about your care or anything, just feel free to email IBD at Cleveland Clinic Abu Dhabi.ae. This is our IBD coordinator's email. All right. Thank you very much for your attention. I hope you found this helpful. Please remember you can submit your questions in the chat box if you have any questions at all, and we can answer them at the end of the talk. So next up, we actually have Dr. Zahar Kutubi, who will be giving us an overview on our program, the IBD program at Cleveland Clinic Abu Dhabi. So Dr. Kutubi is a consultant gastroenterologist at the Cleveland Clinic here and is specialized in IBD. So go for it, Dr. Kutubi.
Hello, everyone. At the beginning, I would like to thank Dr. Sarah for organizing this meeting, and I would like to thank all our colleagues who are participating in this meeting who was made specifically for our patients. Now, we are here to support our patients and to try to ease their challenges. So my task today is to talk to you briefly about Cleveland Clinic Inflammatory Bowel Disease Center and Program, which has been going on since 2015. So we need to get to know each other through this program. The inflammatory bowel disease is a very common medical problem in the United Arab Emirates. The number of local patients with inflammatory bowel disease is increasing every year. The cases which are seen, frankly, they are not different from patients who are seen in the West or in the US or anywhere in the world with regard to the clinical presentation, the management, the morbidities, and also the mortality. The mission of the Inflammatory Bowel Disease Center at Cleveland Clinic Abu Dhabi is to provide a unique service to the population of Abu Dhabi, the UAE, and the surrounding region. And we are getting actually very frequently patients from the Gulf and also from areas surrounded by the Gulf area. And also the mission is to improve the quality of care and life for patients with inflammatory bowel disease. We know how tough is their life, and we are here actually, the center is to provide these patients with the best of help and through the state-of-the-art evidence-based care. Also, the mission of the center is to concentrate on treating both intestinal and extra-intestinal manifestations and symptoms of the disease, and also to be involved not only in the taking care of patients, but also in the basic and clinical research, in educating future fellows, residents, and visiting gastroenterologists, and to help local gastroenterologists also who need our help in managing their complex patients. So who we are. So the center is actually taken care of by different specialties and different physicians. So currently we have 4 physicians who take care of inflammatory bowel disease: myself, Dr. Sarah El-Wali, Dr. Muhammad Alam, and Dr. Usama Youssef. Also, we have our recently joined our coordinator, Mrs. Mary Mayland, who is our great addition to our center and members. We have a great colorectal surgeons. Usually the colorectal surgeons work hand in hand in our center with us. And we have Dr. Shafiq Sidani, Dr. Khalid Madbouli, Dr. Fadl Shabib, and Dr. Lamis Tabaja, who is also a female colorectal surgeon with the great help. We have also the supporting specialties, which I cannot underestimate how important they are. So an inflammatory bowel disease center cannot run only on gastroenterologist and surgeon, but also we have our rheumatologists who take care of rheumatological diseases, dermatology, ophthalmology, our great pathologists who read our slides, our radiologists who read our MRI and CTs. We have a great clinical pharmacist who sit with our patient and explain to them the medication. We have a great nutritional service who they see these patients and they discuss with them what to eat, what not to eat, and the diet. And also we have a unique stoma nurses services, usually for patients who require to have stoma and surgery. So we are very privileged and very lucky in Cleveland Clinic Abu Dhabi to have our infusion center, where we give the infliximab, the vedolizumab, the ustekinumab. These are the biologic treatment with most of our patients they know about, in addition to give the iron therapy. We are very, again, lucky to have a great team with us, because this team usually they meet every 2 weeks. We call it inflammatory bowel disease multidisciplinary team meeting every 2 weeks to discuss all the difficult and challenging cases. This team usually is attended by us gastroenterologists, by the colorectal surgeon, pathologist, radiologist, and also by our own coordinator. So just to give you an idea where we stand today, we have 818 patients, which has been accumulating for the past 6 to 7 years. 70% of our patients are locals, 30% are non-locals, and we have more Crohn's disease patients. 56% of our patients have Crohn's disease, 44% have ulcerative colitis. So as you can see, the disease is very prevalent in the UAE, and we are here to support our patients, and we are very glad and happy that we have a wonderful team to serve our patients. So thank you so much for listening. We are very happy to answer all your questions at the end of this webinar. Thank you so much.
Thank you very much, Daher, for this great talk. I hope you all found this helpful. So next up, we actually have Marie Maynard, our IBD Nurse Coordinator, who will be talking to you a little bit about what her role is and how she can help you and support you. Marie, you're next.
Thank you so much, Dr. Sarah. I will be discussing the role of the IBD Nurse Coordinator. So first of all, let me introduce myself. My name is Marie Maynard. I have worked at Cleveland Clinic here in Abu Dhabi for 5 years, and before that I did my training and worked in the UK. And my current role is the IBD Nurse Coordinator. We will start with, what is the IBD? Sorry, can I start again? I just realised I was. Thank you so much, Dr. Sarah. I will be discussing the role of the IBD Nurse Coordinator. So let me introduce myself. My name is Marie Maynard. I'm the IBD Nurse Coordinator here at Cleveland Clinic, and have had the pleasure of working at Cleveland Clinic Abu Dhabi for 5 years. Before that, I studied at the University of Brighton in the UK, where I am from. What is an IBD team? The IBD team consists of many healthcare workers with specialist inflammatory bowel disease experience. We work closely with one another, meeting regularly to discuss our patients and how we can help them. This makes sure you as a patient are able to receive safe, consistent, high quality, personalised care. And what is my role as the IBD Nurse Coordinator? First of all, the IBD nurse is available to the patient as their first point of contact. This can be regards to symptom flare-up, appointments, labs, advice, or generally anything in regards to your inflammatory bowel disease. We communicate among other departments and with your doctor to ensure your treatment plan is carried out appropriately and timely. We also specialise in education. It's very hard for the patient and a relative to keep up with various aspects of your disease. And that's where I'm here to help. I'm here to listen, to learn about you and how IBD is affecting you and your family, to get to know you and to help you. Here are the main things we consider for a person who is living with IBD and how their life can be affected. Physical, we have tiredness, symptom flare-up. Emotional, patients we find can suffer from anxiety or low self-esteem. Social, which can involve travel or the complete opposite, isolation. And occupational, increased sick days or the inability to work at all. An IBD patient can have a normal and good quality of life. With ongoing studies being carried out, and as you can see on the screen, the access that the patient currently has to all of these services, we know that you can lead a life with great quality and on the correct treatment plan that is personalised to you. Another large part of my job is health maintenance. Health maintenance involves finding a problem before it becomes a problem and maintaining good health. Unfortunately, having inflammatory bowel disease, it can increase your risks of other diseases and infections. We offer and encourage patients who have to have regular screenings in line with national guidelines in order to rule out and or diagnose early other problems and get them sorted as early as possible. This includes patients with who may need the help of smoking cessation. We encourage all patients, but especially IBD patients, to stop smoking, and we offer the support where needed. Last but not least, as part of maintaining good health, we encourage vaccinations against all preventable illnesses. This includes COVID-19. We know that IBD patients, unfortunately, suffer more severe and complicated illnesses if they happen. So we encourage and we can help you through keeping up to date with all your health maintenance. That's all from me for now. Thank you so much. Please do contact the IBD at Cleveland Clinic Abu Dhabi.ae for any, without hesitation and for anything that you need. Thank you so much.
Thank you very much for your attention. I hope you found this helpful. And so thank you also to the speakers for these great talks. So next up, we actually have the Q&A. So if you have any questions, if you haven't already done so, please type them down in the chat box, and we're very happy to be answering all of them. Hello. Hi, everybody. Hi, everybody. So I hope you enjoyed this session, and I hope you can hear us and hear me properly. So we have a couple of questions to start. Again, if you think of anything right now, just please type your questions in the chat box. And any question is really okay. All right. So first, I'll start with a question that we just got about the age of patients we see. So we see patients above the age of 14 years old. So we treat patients, give them medications or see them or do endoscopies and all the testing in all patients above the age of 14. And so for the other questions I have, so just to reintroduce my panelists, I have Dr. Zahar Kutubi here with me that you've just met, and also have Marie Maynard with me, our IBD Nurse Coordinator. I do not have Dr. Alam today. He couldn't join us, but will be here to answer any of the questions you have. Second question. So is it safe to take COVID vaccine even if I am taking cortisone? Dr. Zahar, do you want to answer that question?
So the question about taking the COVID if the patient is taking cortisone. Well, usually, we don't like the cortisone while patient taking vaccine. Usually, at least has to be a very low dose, or at least has to be 2 to 3 weeks after the finishing of the prednisone dose. If I also can modify the question, some of them, they ask whether it is okay to take the vaccine while taking the biologics. At least there's no contraindication to stop or the infusion if you want to take the vaccine, but usually we take usually 1 week in between. That will be enough. Have any comments, Sarah?
Yeah, no, I agree. In general, what I do tell my patients is there's no harm, right, in taking cortisone. Absolutely not. What we don't know yet is whether it's as efficient or as effective if you take it when you have cortisone. And we'll know that in the future when we have more studies. But there is absolutely no harm in taking it. And so because we know when you're taking cortisone already, your disease is not is actually active, you are at high risk of COVID. So, Zahra, I actually tell my patients to get it as soon as they think about it, as soon as they see me. Go get your COVID vaccine. It's really important because that's really what's going to protect you at the end of the day.
Yeah, so there's no contraindication for the vaccine. And the most important actually is to take it. This is most important for people to know.
Absolutely. Absolutely. Thanks, Zahir, for emphasizing. So we have a lot of actually really interesting questions that are popping in. For the next one, Marie, I'll answer a little bit and then I'll let Marie chime in as well. So as we approach summer, how do we manage medications during traveling? That's a great question. So especially that a lot of us haven't traveled in a while, and so getting used to this new reality. So medications, usually you do let us know, or let your medical team know ahead of time, because we do want to make sure you have enough of the medications with you. Sometimes if you're on injectable medications, you might need a letter from us that says that you're okay to travel with injections, essentially just, let us know what type of medication you're on and where you're going, and how long you're going for, to kind of plan how much you'll need. I know, Marie, you've done this a few times recently. So any advice you have to give to any of our patients traveling? Marie, you're muted. You're still muted.
There we are. Hi. Yeah, it's so great to see people being able to travel again. So it's really a great job for us to be able to do. Like Dr. Sarah said, I think the main thing is just give us as much time as you can. Obviously, some trips are last minute. As much time as you can so we can just organise all your medications, any correspondence we need. If you can, I think the main thing, which not everyone knows, is to give us your start and end date so we can know exactly how much medication to give you. But yeah, that's it. It's quite simple once you know how. It's just you just have to leave it to us and give us as much notice as you can. That's all.
Very good. And I'll add one more thing, Marie, because you've had to gone through this recently, is that a lot of times pharmacy will ask for your plane tickets.
Yes, yes.
Dates, and just to prove that we can give you a lot more medications than you're technically allowed to get.
Exactly that. Yeah, it's mainly the insurance that want everything. So once we have all the paperwork, we can actually get it done quite quickly.
Thank you, Marie.
Thank you.
I hope that answered your question. Next question, perhaps Zahra, if you can take that one. So thank you, team, for the webinar. I have a question. How long the treatment should be continued?
Okay, so we're talking about the IBD treatment.
IBD treatment.
Well, there's no really, we can't tell when to stop your medication. What actually, what make us decide when to stop your medication is how you're doing. Basically, there is no clear evidence at this point. Should I stop medication after 1 year, 2 years, 5 years? If the patient is doing well and we achieve from the beginning what we are looking for, whether this is improving patient symptoms, whether improving the endoscopy, whether to improve the, now we come with the histologic improvement, if the biopsies are fine. So if all of that patient achieve what we want him to achieve, actually to get better, symptom-wise, endoscopic-wise, X-ray-wise, then we may actually ask the patient to stop medication. Now, how long did that take? A year, 2, 3? It's really very difficult to tell.
Exactly, Zahra. I completely agree. Sometimes it does take time to get to that remission. But I'll say even when we're in remission and that, you feel back to normal and your bowels are back to normal, on endoscopy, we always have that discussion. If we do stop the medication, there is a risk of flare, unfortunately, and we estimate this risk to be almost 50% at 1 year. There's a study that just came out at DDW just a few months ago, that, up to 50% risk of flare again within a year. So it's something that we always, of course, medications can be stopped, but we always have to have a really careful discussion, just like Zahar was mentioning.
And also very important to know that feeling fine does not mean that your disease is under control. So when we ask the questions, how you doing, any pain, any diarrhea, any bleeding, any constipation, any nausea, vomiting, any sign of obstructions, these all actually count only for at least 30 to 40% from our evaluation of the case. MRI, blood tests, stool studies, colonoscopies, biopsies, that's what actually emphasize and that what tell us how you're doing, not only how you're feeling.
Exactly. That's really important to focus on that. Absolutely. So then we have other questions. We actually have quite a few. So next up, what is the difference between IBD and IBS? I can take that question. So IBD, inflammatory bowel disease, as we talked about, affects your bowels. It causes inflammation of the bowels, and it's something you can measure. You can actually see it either on the scopes or on CT scans, MRIs. IBS is irritable bowel syndrome, and they're very often confused just because the name sounds so similar, but they're very different. Irritable bowel syndrome is more of a syndrome in the sense that the bowels are completely normal. There is no actual disease per se, but we call it sensitive bowels in the sense that patients can get diarrhea, constipation, abdominal pain, but it's a lot of, food sensitivity or sensitivity to stress or traveling or changing patterns, but not actually leading to inflammation. And that's really important because the treatment is completely different. So that was one question. Another question, Zahar, if you'd like to take it, do you recommend long-term PPI for IBD?
Well, again, it has an indication. So some people have upper GI involvement when they have gastritis and duodenitis. Yes, definitely they should be on PPI.
Absolutely. But just to emphasize that PPIs are not a treatment for IBD, absolutely not, but only in that subset of patients that has upper GI disease. Completely agree. As a supplemental medication to the medications that we use for Crohn's. How long do medicines usually last? Zahar, do you want to take that question or should I answer it?
Go ahead.
So medicines, it really depends. A lot of medications we use for IBD, it really depends on the type of medications. If someone is doing well on something like 5-ASAs, we can expect them to do well over time. But the issue is that IBD does have flares. It's ups and downs, And so a lot of the times, the medications don't control anymore the inflammation at that point, and you have to change the medication. And so it's not that they don't last long, it's just that sometimes the disease kind of shows us a different pattern or a different severity, and we have to change to something else. For example, things like certain biologics like infliximab or adalimumab, we know that after a year, about 30% almost of patients can develop antibodies to these medications. And a lot of people after 5-6 years will have had developed antibodies and developed essentially non-response to these medications. But it really depends. We have patients 10 years on the same medications that are doing great. So it really all depends. Anything to add, Zahar, to that?
Not really, no. But I'm looking at one question where people ask, thanks a lot, doctors. Dr. Zahar did not mention Humira injection. This means it is no more benefit from it. Well, for our dear patients, there are 4 classes of medications which we use. The first one is an anti-TNF, which include actually the infliximab and the Humira. The second is the vedolizumab. The third is the ustekinumab, and the fourth is the JAK inhibitor, which include the tofacitinib. So, when we talk about all biologics, we do not mention specifically any medication.
Absolutely. Agree. Thanks for clarifying. And I hope that answers your question. Do you recommend the use of probiotics? Zahar, do you want to take it?
Yeah, so data showed actually that probiotics may make you feel okay, may make you feel better with less bloating sometimes or less diarrhea, but some other data showed has nothing to do with the treatment of IBD. It will not improve your disease itself.
Absolutely agree. The way I tell my patients is, listen, if you feel better on probiotics, because probiotics can improve some symptoms of IBS, which you can also have on top of the IBD, then good, but it's not supposed to be removing the inflammation you have, and you still need those medications to treat the inflammation. Another question: do I have to stop cortisone because of COVID-19? So it's a great question. Um, do I have to stop cortisone? So essentially, what we were saying, and what I was saying in my presentation, is that cortisone is not good in the sense that it increases the risk of COVID-19 and increases the risk of severity of COVID-19. But it's probably just a sign that patients that have active disease and that are on cortisone have a higher risk of COVID-19. If you are on cortisone, we have to always make sure you're on it for the right reason. Maybe you have a really bad flare, and the cortisone is absolutely necessary to get you through that flare, and that will help everything. It will help your COVID risk, because we're decreasing the inflammation as well. But we do see sometimes patients, and I'm sure Zahir will agree, that are on cortisone for not good reasons. And yes, for those patients, definitely we need to stop the cortisone. And as you all know, cortisone cannot be stopped right away if you've been on it for more than 3-4 weeks. So often we have to taper it down, and that's okay. That's how we stop it. But yeah, so that's the thing with cortisone. So definitely, obviously, we would avoid cortisone if possible, but sometimes we have no choice. If I got COVID, how long should I wait before starting my medication again? Do you want me to take that, Zahar? Do you want to take it?
Go ahead.
So it's a good question, and it's been looked at in studies, and we still, the reality is we still don't know what's the optimal spot. But so far what we say is 10 days. So 10 days after you've tested positive, 10 days after you've recovered. So we want you to be fever-free, cough-free, feeling well, and your last positive test to be for at least 10 days prior. But this is really, it depends. It's a case-by-case thing, because if the disease is extremely severe, the IBD is very severe, sometimes we keep the medications. And if the COVID is very severe, then we may keep you off the biologics or the medications for a lot longer. So it's a case-by-case basis, and we discuss them as a team. But in general, 10 days, and it's more than enough.
So if I may add one thing, actually, just for our patient to know, do not delay your infusion. Most of the studies showed that patients who delay the infusion, these are the people who get into trouble. Now, previously, a year ago, we used to tell the patient, if you are twice negative, if your COVID is negative time 2, then you can go take the infusion. Not valid anymore. If you're symptomatically doing well in 10 days, please, you need to take your infusion. Do not delay your infusion.
Absolutely, absolutely, because at the end of the day, that is increasing your risk of badness from COVID and everything. So how frequently the routine blood test to do before and after biologics? I think Marie can actually answer that, because she does see this quite often. So Marie, do you want to answer that question?
Yeah, I can do, no problem. So we try, and obviously when you're receiving your biologics, you're having a cannula. So we actually try and do it at the same time as your infusion, just for yourself, really. And we do it every 2 to 3 months, I would say. Obviously, each blood test means different things. So we might, want one every 6 months, once every 3 months, but generally it's every 3 months at the most.
Very good. Agreed. We usually like to get them every 3 months, just to make sure everything is okay with your blood counts, your liver, and everything. And often it's actually, required by the insurance company to just make sure everything is okay. I'm very mindful of the time. We have 3 more minutes and a lot of very good questions. Another one: is analgesics like NSAIDs indicated for symptom relief? Zahir, do you want to take that one?
Yeah, you may need to be on some medication for pain, but we have to keep in mind that most of the analgesics actually can make your disease worse. They can actually give you a little bit more ulceration in the small bowel, in the colon. So please, if you can stay away from the non-steroidal, will be great. If you want to take Panadol, that's fine, but stay away from the non-steroidal.
Completely agree. There's another question about the study of vaccine efficiency was done in the US with Pfizer and Moderna. How about the other vaccines, including Sinopharm, Johnson & Johnson, AstraZeneca, and Covishield? So far, we don't have a lot of studies, but they're mainly about Pfizer and Moderna. There is a study, though, from the UK that included AstraZeneca, I believe. They included both AstraZeneca and Pfizer. And so, again, similar results. However, the Sinopharm has not been studied in patients with inflammatory bowel disease at all. Just thought I'd mention that. We have another 2 minutes. Oh, very good one. What's the difference between IBD and celiac disease? Zahar, do you want to take that one?
Yeah, so IBD is inflammatory bowel disease where you have an inflammation actually either in the colon, terminal ileum, I mean small bowel, or even in the upper GI, like in the stomach or the duodenum. Now, the celiac disease is basically gluten sensitivity, which can actually give you some inflammation in the duodenum, but it does not look like Crohn's disease because you will have shortening of the villi, the blood test will be different, the pathology will be read differently. So there's a big difference. You know, when you see your physician, this is a long discussion. When you see your physician, they can explain to you better, but they are completely two different diseases.
Absolutely, completely agree. Another question, very good question. When a patient has symptoms but is in remission, does that mean he has IBS? Great question. I can take it. So, no, it doesn't mean he has IBS. It could be a lot of other things. First of all, you really have to make sure you're in remission because sometimes remission can mean different things for different people. Remission means you have to have completely normal bowels and completely normal bowels on MRI, CT scan, colonoscopy, normal inflammatory markers. We have to make sure that the IBD is not active. Sometimes patients with IBD, especially if they've had surgery in their small bowel, can get bacterial overgrowth. So that could lead to symptoms of diarrhea and bloating. You could have also some bile acid diarrhea. You could definitely have IBS. There's a lot, of course, infections, right? Infections are a big one that can lead to similar symptoms of IBD without having active IBD. So I hope that answered your question. And
so Sarah, there's one question above it, which is, I'm feeling fine, but my doctor says my colonoscopy show inflammation. Do I need a treatment? I think this is very important because, as we mentioned, you may feel fine, but the disease is ongoing and you have to be on treatment to prevent the complication of the disease. So being fine, that's what I mentioned initially. Feeling fine, that does not mean that your disease is in remission. We have to have a colonoscopy, biopsies, your blood work, your MRI, all of that has to come into the picture too.
Absolutely. So we're past 7 o'clock and I'm trying to be mindful of our public's time. If there's anything you want to ask us, you can send us questions to the email that we sent you, that we showed you earlier, the IBD at Cleveland Clinic Abu Dhabi.ae. Any more questions? You have questions about your care? If you want more answers, don't hesitate at all. That's pretty much it. Zahar, Marie.
Yeah,
anything?
So one last, this question is very important. What should we do when my biologic medication stop working? So this is also very important for our patients to know that we do not decide to stop medication just because patient is not feeling okay. We have to look at many other things, including sometimes what we use, the TDM, the therapeutic drug monitoring. We check the blood level of the medication. We make sure there's no antibodies. We try to take as much as we can from the first biologic before to move to another biologic. So if your biologic is not working, that need to be decided. We may increase the dose, we may shorten the duration, all of that before we try to move to another medication.
There's one more question. I'm just going to answer it. I know people have to go, but I just want to answer as many as possible. Is there any specific reason why golimumab is not used in practice? We do actually use it. We use golimumab, but not as frequently, and that is true. There is no study that's ever been published comparing golimumab to other medications for ulcerative colitis, but we do have good results with other biologics that we're able to measure very well. Dr. Zahar was just mentioning how we're able to measure levels. So for certain biologics, we're more comfortable doing that for those ones. We have a lot more studies for those. So we usually go for those ones, but there's absolutely nothing wrong in using golimumab. Again, I don't know if we mentioned that, but whatever works for you is great. You know, we just have to make sure that whatever medication is prescribed for you actually is working by making sure there's no inflammation in your bowels. And so as long as we do that, then everything is okay. So if golimumab is working for you, that's great. All right, I think we can now wrap up. Thank you, everybody, for being with us. We do have another session tomorrow in Arabic in case you want to ask more questions. And we will be doing this 3 to 4 times a year. And so whenever we have the next session planned, we'll let you know. And we'll be very happy if you join us. All right. So again, this was the email I was telling you about, the IBD at Cleveland Clinic Abu Dhabi.ae. This is Marie's email. Anything you need, just let us know. Have a lovely evening, everybody. Take care.